Welcome. We're going to go over strategies for technologists to get the best possible cardiac CT scans. In this lecture, we're going to focus on things that you can do before you scan to ensure optimal image quality. And we're going to break it up into two different sections. We have patient prep and we have protocol mode selection. So let's dive into patient prep. Positioning will impact your MA modulation. And poor positioning can actually cause overexposures. So here's an example of the exact same patient in a chest CT. One of them where his elbows are up and above his head and crouched towards his head because his shoulders hurt, and another one with proper positioning sponges. And you can see that for the exact same size patient, we can almost get radiation reduction of 50% right off the bat. And the reason that this happens is because the arms are in the way and we have to shoot through this dense material, and we're going to have to use more x-rays in order to get through that. And it's also magnified because it's not in the ISO center. And you also want to keep in mind for cardiac CT is if the patient is not comfortable, they're going to move their arms, and that may potentially cause issues with your ECG waveform. Now, some of the ECG artifacts that we commonly see are going to be loose lead artifacts. So you can see in this picture on the top, we have a picture of a lead that's coming off, and you can actually tape those down and make sure that the lead stays flush on the surface. Now, this often happens when you place your leads on and then you bring your patient's arms up. So generally speaking, you want to get the patient's arms up with the gown open in front if it's male, or consider just using a blanket for a female so that you can place these ECGs. And this will allow you to make sure that these don't come off. Another thing to keep in mind is muscle tremor artifacts. So if your patient's having shoulder pain and they start to twitch, your ECGs are going to capture that electronic motion, and that may impact when the exposure settings increase or decrease the exposure. You can also get electromagnetic interference. For example, a pacemaker might give you additional electrical information, and that could impact your ECG waveform as well. Now, some patients come in and they've got a lot of lotion, or some patients are post-operative and they're diaphoretic, and the stickers won't stay on them. And so you might want to clean the skin. So you could use a 2x2 gauze pad. You could also use an alcohol wipe. Now, if the patient's got a lot of dirt on their skin, the alcohol wipe works really well. Sometimes you can lose conductivity because you're losing all of the moisture. So to solve that, you can use some ultrasound gel right under the metallic component. Just a tiny bit will work very well there. Now, if you're new to cardiac CT, consider buying individual ECG leads rather than the bulk pack of 50 or 100, because those tend to dry out over time, and those can make it hard for your system to be able to see the patient's actual heart rhythm, because there's not enough of that wet electrode left on it to conduct the electrical activity of the heart so the scanner can identify when to modulate the exposure. So in terms of optimizing the ECG placement, we use the mnemonic smoke over fire and white on the right. And on the new systems, you'll also have a ground lead. The ground lead's always in green, so I think about the green grass under the white clouds. Now, importantly, what you're going to want to think about here is you're going to want to off-center these in the Z-axis, or the head-to-toe craniocaudal axis. The idea here is that if your X-ray beam is shooting through here and you have two metallic objects on the same plane, there's going to be information loss between those. But if we offset these, then we won't actually have any beam hardening in between these areas. And that could be helpful if you're trying to evaluate mammary arteries for a graft selection. And so best practice is always offset these a little bit and place your leads on the thoracic chest wall, so right there on the rib cage. Now, you might have to, play with this a bit. So this is a good way to set up your leads. Here's another good way to set up your leads, just moving it around, triangulating the heart to get as much signal as you can. If you have an issue with a setup like this, then you can adjust it and bring your ECG, your black lead, on the arm if you had, for example, a pacemaker where those leads are conducting electricity. So this is a great way to adjust for that electrical interference. And you could go as high as the bicep. and still get good information in terms of when to adjust and modulate the exposures based on the automated settings that you either program or the vendor programs on your behalf for your modulation settings. So we've had issues with patients that have extremely hairy chests where the stickers don't stick on the chest. And so you're going to need to shave these patients. And I find the best way to shave the patient is to have some tape that's backwards on the hand, and then you can just wrap it around, and as you shave you can pat it down so you don't get this hair all over the place. And that's part of proper room etiquette. We want to keep things clean. We can essentially just turn the glove inside out and throw that away at the end. And in terms of room etiquette, another thing to consider is that oftentimes we're real busy and we can actually get these little pieces of contrast stuck on the Mylar screen, and those actually can lead to artifacts as seen in this head CT, where you have these absorption characteristics outside of the 50 field of view, and that leads to out of field artifact. So be mindful if you're imaging or you're starting your contrast or you're connecting your contrast in a way that's messy. You'll want to clean up your contrast after every patient. Now, most scanners will actually ask you to do a Mylar check during the morning calibrations. So this generally won't happen for longer than a day. However, you want to keep in mind that if it's on the table, you're not going to get a warning from the system saying you're going to have artifacts because your Mylar screen is dirty. So best practice, just always keep everything clean. And the general workflow for CT, regardless of the organization that you work for, is that you're done when the room is clean and ready to accept the next patient. This is particularly important when you're working in an application in a hospital or in trauma stroke code scenario where you need everything good to go, ready to go, and clean. Now, another thing to consider is that your contrast needs to be warmed to body temperature. Now, a lot of people aren't doing this because the Joint Commission has asked for you to keep records of up to, I think, 3 months at this point of daily temperature logs, and you can't exceed the body temperature, and if you do, you need to create a variance and you potentially have to waste the contrast, right? And you also reduce the shelf life to a month. So why would you want to raise the temperature of the contrast to body temperature? And the issue here is viscosity. So we have ISOView 300, which is 61%, and 370, which is 76%. And as we decrease or increase the temperature from room temperature, it was 20 Celsius, to body temperature, which is 37 Celsius, we can effectively change the viscosity and cut it in half. And that will lead to reduced injection pressure, so decreased patient motion due to discomfort of the injections. It'll allow us to inject a little bit faster. And so generally speaking, whenever you're injecting contrast, you want to inject body temperature contrast, or just under body temperature, to reduce some of the viscosity associated with this dense material. Now, another thing to consider for CTAs is you're going to want to use large bore IVs. Generally, you're going to use an 18 to 20 gauge. These are less painful to inject because they reduce the injection pressure compared to smaller needles that will have faster jets. Now, we use the BD Nexiva Diffusix closed catheter system. These have two benefits. One, the connection tubing is attached to the catheter, so you don't have to worry about potentially getting a little bit of blood on your work area when you're inserting one of these IVs, because you don't have to connect them. They don't disconnect because a floor nurse sent it down and tightened it that sufficiently for medicine injection, but not necessarily a bolus. But the reason we use these in CT specifically is because we have these diffusion ports that allow us to inject and then have the contrast go in 4 different directions, which massively reduces the injection rates. And so instead of having 20 gauge and 18 gauge IVs, we're now using 22 and 20 gauge IVs. 22s you can inject at about 6.5 mLs per second, and then 20 gauge you can go up to 10 mLs per second. So pretty much you can cover every cardiovascular, every patient's body size with that 20 gauge. Now, in terms of protocol selection, there are a few things to consider. First thing you want to think about is you want to optimize your scan mode based on your patient's size, right? Do you have a small size patient, a large size patient? What's the patient's age and radiosensitivity? Are you imaging a young female or an old man? And what's that clinical need specifically? Are you trying to replace a valve? Are you following up on an aortic stent graft? Now, how would you optimize a cardiovascular scan? Well, you could optimize for image quality by reducing exposure in follow-up examinations or increasing exposure in primary examinations so that you get better detail. You could optimize for radiation dose for really young patients or radiosensitive patients. You could adjust for iodine specificity or beam hardening correction by altering your energy or KVP selection. And the requirement for cardiac phases will alter the way that you perform your images. Now, it used to be that cardiac gating meant cardiac mode, or essentially getting a still image of the heart. But now there's actually several flavors of cardiac mode. And so the ones that we use in our organization are mainly dual source or wide detector mode. And so if you require localized motion suppression, any of these systems will do it. You can use the flash mode, you can use the adaptive sequential mode or perspective step and shoot mode, you can use the traditional retrospective mode, or you can use a wide detector scan mode, which just has a massive 16 centimeter detector where if you wanted a whole chest, it's essentially 2 rotations around the patient. Now, depending on what you're looking for, some of these modes are better than others. So if you're trying to evaluate a patient that can't hold still or follow breathing instructions, then flash mode's really the best way to go. Trying to apply any of the other modes simply doesn't give you good images. So we love the flash mode for this application. And if your patient requires low radiation dose, I think the flash mode's a really good way to do it. So is the wide detector mode. For that matter, you can use the sequential mode, the adaptive sequential mode, or the perspective step and shoot mode if you'd like. However, you generally will need to add some padding and make some background optimizations beforehand if you want to make this kind of a low dose acquisition. And with retrospective mode, you can do that assuming that your automated settings are set up correctly and your patient has a steady heart rhythm. Now, if your patient requires just a single cardiac phase, I would say they all work except for the flash mode. That doesn't work as well because it's taking several different cardiac phases and superimposing them over maybe a third of a second. And I'll show you what that kind of looks like in an animation a little bit farther on in this lecture. So if your patient requires multiple cardiac phases, let's say you want to look at a dissection flap open and close, or you want to look at a valve that you deployed and make sure that there's no leak in the area that you've placed it, then you really shouldn't use the flash mode. And you could potentially use the adaptive sequential mode, but you'd have to essentially image between systole and diastole. At that point, you might as well go back to a retrospective or a wide detector scan mode. And then if you need to do any post editing, let's say your cardiac scan doesn't come out correctly, you can forget about it in flash mode. You need to use every x-ray in order to reconstruct your images in flash mode, so there's no editing with that. Adaptive sequential mode can allow some editing. You can't remove different heartbeats, but you can change the temporal window. Retrospective mode allows you to choose from the central or peripheral detector areas in terms of editing, so you can say, I don't want to use this entire heartbeat. And then wide detector does something that's exceptional, which is not only do you get the full phase in one cycle, but you can also program into it that you want it to take an extra picture if you have variation greater than 30%. So you can build some smarts into the wide detector scan mode that makes it very robust. Now, in terms of compatibility with cardiac arrhythmias, the flash mode is very, very good for that. We use flash mode in cardiac arrhythmia for pulmonary vein mapping pre-ablation. We use it for our PE studies. We use it for our pediatrics. It works very well regardless of heart rate. It's just a really fast image. Now, you can use adaptive sequential mode with cardiac arrhythmia if you limit your scans to a millisecond value of systole. Same with retrospective scan modes. If you don't do it in the retrospective scan mode, then you could potentially use one of those really traditional high exposures, because the system won't know when to downregulate. So that's specifically when you're using the percentage relative value to identify when to up and down regulate the tube current. Now the wide detector scan mode, that is very compatible with the arrhythmia. In fact, you don't have to put several heartbeats together. I've got an example of that I'll show you in a little bit. The wide detector works very well with cardiac arrhythmia. And in terms of temporal resolution, or your image capture time, on the dual source systems, you can use 1/4 of the rotation time is roughly going to be your temporal sample rate. So if you're anywhere between 65 and 75 milliseconds is your image capture time. With your wide detector system, you're going to only be able to use a half rotation time. So it's actually 150 milliseconds image capture time. And the flash mode, while it captures at that really fast temporal resolution setting, it doesn't necessarily reconstruct over that one phase. In fact, it's going to pull multiple phases together. So let's take a look. So assuming you need physiology and you need to watch the heartbeat, for example, here's a valve deployment, and we can see that there's this contrast leak around the insertion site where they place that valve. You wouldn't be able to see this if you captured one moment in time. And so it's really important to understand that if you're evaluating a valve or a dissection flap and you want to make sure that there's nothing wrong with the surgery, you might want to consider doing multiple cardiac phases in order to evaluate for this. Now, if your use case turns into just an aortic stent graft or just motion suppression in the aorta because you have a transfer patient and the aorta was motioning and you didn't know if there was a dissection, or if you're doing pediatric examinations, then the flash mode works really well and it's extremely low dose. And this is a great approach to motion suppression of the aorta. So we'll use this for pulmonary veins, aortas, PE studies. This is a great mode, but it's not going to necessarily give you as much information as the prior case where we could actually see the leak that was physiological and based on that cardiac cycle. Now, if you need coronaries, you could potentially flash, but again, you're going to have some issues here because your temporal sample is the scan time, and that's the uniformity. And so while it looks really good proximally, here on this curved planar reformation, you can see that we actually have this coronary that's actually moving from here to here during that temporal sample time, and you can see the double border. So you can see that it's here and here. You can't really rule out pathology in this. There's just a lot of motion. And when you compare that to an adaptive sequential or a retrospective scan mode, you can clearly see the difference of a retrospective scan giving you these firm borders, and you can better identify what's happening because your temporal sample rate is now down to 66 milliseconds as opposed to 300 milliseconds. Now, does that mean that if you're using retrospective scan mode that you're going to get really high dose values? Not really, because if you look down here at the ECG waveform, I'm actually showing you here these dotted lines are the down regulation. We're using the minimum dose function or the min dose function, and we're only imaging in diastole where this solid line is at full dose. And so we're following our LAR principles, and we're reducing the exposure outside of diastole considerably. So we're still being very dose conscious and getting great images, but now we don't have to worry about some of these temporal artifacts associated with flash mode. So another example of why temporal resolution is important. Here's a wide detector system where the diastolic phase was at 75 BPM, and this actually caused not only a washout of the contrast because the heart rate increased dramatically, but it also made it so that the object was moving so fast that we can't even see this calcification that we clearly saw during the calcium score. And I'll walk you through how this occurred and how you can avoid this in the future. Before I do that, I want to talk about why the wide detector mode is so great, and that is here we're performing a mitral valve replacement. We need to be able to evaluate the mitral valve as it opens and closes. And so you can see that the valve opens and closes on the wide detector system very well. But on the dual source scanner, where we actually have multiple heartbeats being put together with this arrhythmia where we need diastolic imaging, the diastole phase is actually not the same. It's not alike. And so you're getting this weird line artifact through the cardiac cycle. And so it's very hard to map out the actual mitral valve plane and the size and the shape. And that's really what's required in order to be able to tell a surgeon, okay, this is the actual size and shape during end systole and end diastole, and this is what we would recommend that you use to plan your surgery in terms of choosing the right size. And the way that it works is that you image over the entire cardiac cycle, and you can pull your cardiac phase specifically from one area, and then you can identify its maximum closed position and then its maximum open position, right? And now we can clearly see what we need to in order to best help the surgeon help the patient. Now, the reason that this worked so well in this example is because this patient had a pretty substantial arrhythmia. And so if you look here, we have this very fast heartbeat and this slow heartbeat and this fast heartbeat and this slow heartbeat. And when you're looking at diastole, it all needs to come from a similar size shape heart. And each one of these represents approximately 3 centimeters across on the Z-plane, right? And so if you look here from this R peak to this R peak, 70% of that diastolic phase is essentially at the end of that ST segment, essentially in systole. And then here, look how much longer the heart had to fill with contrast and blood. So it's much larger here compared to here. And then even here, it's actually taking a systole and putting it in a diastole. So we have a systole plus a diastole plus a systole plus a diastole. That's going to give you all sorts of artifacts. And the wide detector system doesn't really matter if this happens, right? Because you're only taking it from one heartbeat, whether it's slow or fast. Now, ideally, if you do have that arrhythmia, your system can be programmed to take a picture with the fast heartbeat and then take another one during the slow heartbeat, and then you can choose the one you like. This one's generally going to be easier to view because it's not moving as much. Now, if you're looking at all of the cardiac scan modes and comparing them, this is a picture that I like to think about. So if you're using flash mode, you're taking pictures at extremely high temporal resolution, but from different phases of the cardiac cycle, and they don't quite line up right, but they really are pretty sharp, assuming your object's not moving. Now, if you do the wide detector mode, you can get all of those pictures. You get rid of those stacking artifacts, but it takes a lot longer to reconstruct your image because you're using a half a rotation as opposed to a quarter rotation. So you might get a blur in some areas. And if you use the retrospective or the prospective mode, then you get a chance to take whatever your detector allows you to take in terms of width, and then it steps and moves on and it takes the other piece, and you might have a stack artifact. And this is always a useful way to image during systole, but if you need diastolic images, this will really ruin you if you're in some sort of AFib or irregular heart rhythm. And in general, the retrospective and prospective mode with the dual source systems really only fall apart when your object isn't lining up, and it might not line up because of breathing artifact or might not line up because of an arrhythmia. So a few system specifics in order to get the best possible pictures is based on how you place your MA modulation settings. So on the Siemens system, you optimize the pitch and the exposure settings based on the patient's heart rate after the pre-monitoring image at the time that you hit load and start your injection, right? So right before you start your injecting, you hit load and then you hit start, and load locks in the pitch. If you're in adaptive sequential mode, it's going to lock in your modulation settings, right? And you want to do this right before your injection. If you're doing a coronary scan, you want to do this after the nitroglycerin because this is really important. The nitroglycerin is going to cause the heart rate to go up because of the vasodilation. Now, if you're on a GE Revolution on the wide detector system, it's going to be based on the last cardiac recording. So you want to make sure that cardiac recording is done after the nitroglycerin as well. And it turns out that you can't redo the recording after you've taken your initial smart prep. So you want to make sure that you give your nitroglycerin, you wait 2 minutes, it's dissolved, it's time to scan, record the heart rate, make sure that it represents as close as possible as to what it's going to be like post nitroglycerin, and then you can take your smart prep, you place your ROI, you start your injection, and your bolus tracking at that time, and that should resolve the problem. And that's actually what happened here. Was we recorded the heart rate and it looked beautiful in the calcium scoring, and then we went ahead and we gave nitro, and then after we gave nitro, we took our initial monitor scan, or smart prep, and that locked in the heart rate that was perfect for the 50 BPM, and the heart rate went up from 50 to 75, and then we only had diastole. And because we only had diastole, we didn't have the temporal resolution required to image this clearly defined calcification that we saw earlier in this patient. So with that, these are essentially things that you can do to ensure optimal image quality before you scan. There are positioning things that you can do with the arms. You can use sponges. Look at how you're setting up your ECGs, making sure that the contrast is warm and that you have proper room etiquette, you're keeping it clean. And then the protocol selection is really important. So choose the right scan mode for the job and the task at hand, and identify what protocol is definitely going to work best for your clinical indication. So whenever you're imaging a patient, it's not enough to look at the protocol. You want to look at why you're doing this exam. So check out the reason for the exam and try and match that up with the scan mode that you're going to use in order to optimize your exam for your patient. And with that, I thank you for your time.